Good morning, everyone. Good afternoon, good evening to wherever you are. Welcome back to the fourth day of the International Conference on Inclusive Insurance 2021. Today, it's digitization facilitating inclusive insurance. At the same time, 3 of the sessions today will also touch the topic health. So it's kind of the combination of digitization and health. Yesterday, we were talking about the challenge of reaching the client distribution channels. We saw the Jamaican part. We had 4 sessions taking place in Kingston, Jamaica. We heard the Minister of Finance announcing that Jamaica will launch microinsurance legislation by the end of this fiscal year. So that, I think, is very great to hear. And we heard about digital payments and how to use digital tools for increasing outreach in Jamaica. Now, digitization today is also our topic, and I would like to thank Kwasi Bahane from Farm Access. He is the Director, Advocacy and Partnerships. Thank you very much for facilitating that panel. Thank you very much to the team in the back, Liam, Farm Access, for putting that together. And thank you to all the panelists. We have a very exciting, very diverse, interesting panel here today. And I hand over the microphone to Kwasi before I walk you very quickly, after I walk you very quickly through the housekeeping slides. So please put that on. Now, please put your microphone on mute while others are speaking. The session is being recorded and we make the recording available online after the conference. If you have a question, put it in the Q&A feature. Don't put it in the chat. If you have a comment, you can put it in the chat, but in the Q&A, it's easier for the panelists to manage the questions. And if you have any technical issues, please message the MIN executive team. Now, thank you again. Warm welcome. And Kwasi, microphone is yours.
Thank you very much, Derek. And once again, welcome to this session where we're going to talk about the role of mobile technology in facilitating financing and of health. We're privileged to have an esteemed panelist. So I'll do a bit of introduction as Derek has already introduced me. I'm with Farm Access, and Farm Access is working on using technology to influence financing and delivery of care. For this session, we have Dr. Lydia Selby, CEO of National Health Insurance Authority Ghana. NHIA is one of the biggest public health insurance agency in Okunola, senior health specialist of the World Bank, and is based in Abuja, Nigeria. Tis Cruising is venture leader connected primary care solutions with Philips. Then we have Dr. Bumi Jetawu Winter, Executive Secretary, Kwara State Health Insurance Agency in Nigeria. And Kwara State has been at the forefront of state health insurance schemes. And then last but not the least is Calvin Masingham, Director, Risk and Resilience, FSD Africa. Welcome to this panel. Just a few rules to add to what Derek mentioned. This panelist discussion will consist of 2 parts. So the first part will be an interaction between me and the panelist. I'll ask them questions and then they will respond, and the panelists can also react to contributions from each other. And then the second part will be questions, observations, and responses from the audience to the panelist. So let's get started then. And for the sake of time, we will just go straight into the discussion. So, Olamide, are you here? Yes. Certainly, you work for the World Bank, and the World Bank has been at the forefront of ensuring sustainable financing of healthcare. And in your work, you've been supporting countries across Africa. And just to kickstart the conversation, I would like to hear from you what you consider to be the best options for financing health, and how the World Bank in Nigeria is supporting states or the federal government to achieve this. Please, Olumide.
Thank you very much, Kwesi, and I hope you can hear me clearly. Just straight to say that the World Bank has put universal health coverage, the principles and tenets of universal health coverage, at front and center of what we do in terms of health sector reforms. And that concept of universal health coverage is also something that's been adopted by several countries, across the continent, across the globe, as the aspiration of their health systems. Indeed, the concept of universality embedded in UHC provides policymakers, stakeholders to move forward with a cardinal future, which will be important to this discourse. And that is the role of public financing. For countries that have attained universal health coverage, none has done so without using general revenues. So just to say that the last 12 months, however, has also stalled and indeed slowed down the pace of movement towards universal health coverage across several countries, with the kind of severe fiscal contractions and recession that's happened in those countries. So whilst we're saying, yes, public financing is key, and yet economies are contracting, then what are the kind of policy options that countries have now? One key message to say on this platform is that despite the fact that, yes, there's a downturn in the economy, this is not the time to stop spending. In fact, the way to get out of this crisis is to indeed increase the level of spend across human capital sectors, including health. Of course, as you know, without vaccination, without bolstering health security, with investments in laboratories and surveillance systems, we're not going to overcome the pandemic. So overall, public financing is key, is central to the concept of universal health coverage. And just the last point I'll also make is that the crisis also has provided a pretty unique opportunity for advocates of universal health coverage, because we now have an opportunity to even grow the pie in a much more bigger way. There's now this resurgence to advocate for pro-health taxes. This is health damaging products, alcohol, tobacco, sugar sweetened beverages. I think the COVID crisis has shown a light onto the health sector and the kind of demands that is required in terms of financing. And I think for several countries that have not utilized this opportunity, this is a time to also contribute to having additional revenues coming from such products, coming into the general pool, but indeed, stakeholders can also advocate for earmarking such for increasing spend in the health sector. Back to you, Kwasi.
Thank you very much. Can you all hear me? Because I got the message that there's perhaps something wrong with my microphone. Okay. Yeah, so then on the second part, what are some of the steps that you've taken to support states?
Is this for me, Kwasi?
Yes, please.
Oh, okay. So essentially, as you know, in Nigeria, the level of out-of-pocket expenditures is indeed very high, just as the level of poverty, not only high, but increasing due to the COVID crisis. And but putting all of that together, we also need to acknowledge the high level of informality in Nigeria as a country, and indeed across several sub-Saharan African countries. So a couple of things that we're doing is helping to advance the policy agenda for the concept of universal health coverage. Nigeria and its subnational entities are not spending enough on health. So first, there's a need to, at a much more macro level, to see how governments at the national and subnational level can improve their revenue enhancing capacities. How do they mobilize additional revenues, improve tax efficiencies? But beyond that, how are we able to help stakeholders, decision makers, prioritize health? So we have a large human capital development agenda across health, education, and the social protection sectors, and coming really to the level of the state, we work with several of the ministries of health to build capacities within their state health insurance agencies. As you know, the concept of having subnational health insurance agencies is pretty new in Nigeria, most of them at a very fertile stage now. So there's a lot of capacities that's needed in terms of the governance and institutional arrangements and the technical capacities that needs to make those institutions function and implement their strategic purchasing reform, which really is the reason why they were set up. So you're talking of defining the benefit package, and there's a lot of discussion around, how to do that, and even conversations around, what will be the most practical provider payment arrangement, considering where Nigeria as a nation is coming from.
Yeah, thanks a lot for that description and providing an overview of what you consider to be the best options and the role of the World Bank, particularly in Nigeria. Lydia, if we come to Ghana, I've always, it's not me alone, but I think based on statistics, you have the biggest public health insurance scheme in sub-Saharan Africa. And this is an international conference, and certainly most people haven't heard much about your scheme. And in Ghana, could you highlight some of the main features of the scheme, emphasizing especially the financing, contracting of providers, and the healthcare benefit package that Olumide described?
Thank you very much. And good morning, good afternoon, good evening to all those who are listening. Ghana's NHIS was born about 17 years ago, and it's a hybrid scheme. It is partly tax funded. We have a special dedicated health insurance levy, which is 2.5% of goods and services in the country, which is put into a dedicated fund. The formal sector workers, 2.5 percentage points of their pension contribution is also put into this fund. And the informal sector pay a token premium. It isn't actuarially determined, and it's about the equivalent of $4 a year. But there are huge exemptions for under 18s, over 70s, pregnant women, and certain key categories of people designated by the Ministry of Gender and Social Protection. The tax component in most years forms between 65 and 70% of the funding of the health insurance scheme. Now, one thing about ours is that everybody was included from inception. formal and informal. In fact, every legally resident person in Ghana is entitled to be a member of the scheme. In the same regard, we made sure we included all providers in Ghana as long as you meet the standard quality requirements. And that includes the private, the public, as in government-owned, quasi-government-owned, and even faith-based facilities. As long as you meet the minimum requirements of being part of the scheme. And we use the credentialing process to ensure quality before you are contracted to provide healthcare services for the providers. This allows us to drive quality improvements within the health sector. And lastly, about 90 to 95% of the disease burden of Ghana is part of our benefit package. But it is mainly curative, and that is a drawback. And as we all know, funding preventive care and some of the other care like mental health work with counseling has its own peculiar challenges when you are running a health insurance. And finding the right mix of provider payments is what is holding us back. But we are obviously, if we want to achieve universal health coverage, these must be factored in, and we are working on using evidence and data to drive the new inclusions and the expansion of our benefit package. So I think those are the main highlights of our scheme. We've tried to really look around the world, pick up the best parts in terms of principles and adapt it to our country context. And therefore it works for us. Thank you.
Yeah, thank you very much. We will certainly come back to that. And I think also in the questions and answers, there will be some interactions there, because I consider the model to be one of the best, particularly for the key role that government is playing, but also how you've been able to contract both public and private healthcare providers to deliver care. Bumi, so Kwara has been described as the Mecca or Jerusalem of state insurance, based on one's religious convictions. And you've been the executive secretary of the Kwara State Health Insurance Agency for some time. Could you inform us a bit about how you are supporting the delivery of healthcare through insurance? You're on mute.
So good morning, good afternoon, wherever you are. Thank you so much, Kwasi, for inviting me to be a panelist. To put what we do in Kwara into context, I think we need to have some background information about the demographics here in Kwara. So Kwara has an estimated 3.4 million population. We have about 51% males and 49 female. We have children between ages 0 and 14 years, forming about 1 million of our population. We have projected that our indigent population and our vulnerables form about 30% of our population, which makes them about 1 million plus people. The two main pillars that we almost focus on in providing universal health coverage here is having quality healthcare services that is affordable and accessible without breaking the bank or without financial implications, catastrophic implications for the populace. In Kwara, we started off with an enabling law that sort of highlights what we do here and what forms the basis for our implementation process. The law, some of the major highlights of the law is that it is mandatory in Kwara that every resident has health insurance cover. It further states that at some point, every resident in the formal and informal sector will have to show a proof that they have a health insurance cover, and there are sanctions also imposed for those who don't have health insurance cover. It also makes allowance for 1% of the consolidated revenue of the state to be injected as equity fund for subsidies for the indigent population. It also defines as funding sources. The sources would be from the formal and informal sector contributions as premiums, the 1% consolidated revenue of the state to subsidize our indigents, also funding from the federal, NHIS and the federal government, and also donor funding. Now, also in Kwara, we had some leverages at the commencement of our statewide health insurance scheme, in the sense that Kwara had implemented a community-based health insurance scheme in the past. So that gave us some leverage with regards to how we strategize for this new scheme. We also had a leverage with Farm Access having been our technical partners since the days the years when we implemented the community-based health insurance. So essentially, our state scheme was a scale-up of the community-based health insurance scheme. So our benefit packages were designed using our available data to identify what our disease burdens are in Kwara with the assistance of Farm Access Foundation. We also had them assist us with development of all our process documents. So we had all those things in place. I may say the law also defines the population segments we were to cover into three: the formal, the informal, and the indigent sectors. So Farm Access had always been there all along the way. We needed massive support from the three arms of the government for us to be able to get the kind of financing that is required for us to implement a statewide scheme. Critical stakeholders from the executive arm, the legislative arm, and a multi-sectorial approach, looking at where funding will come from the Ministry of Planning, and Budgeting, to make sure that health insurance financing is considered in the budget for the state. You would also notice that our law was passed in 2017. We actually had a launch in 2018, but we really didn't implement until 2020. We went through two political party changes. We started off with a different party, and in 2019, another government came in from a different party. Luckily for us, the new administration had health agenda in its policy thrust. So that gave us some big leverage to get funding available for implementation. So we now have the political will, but even with you having support from the government, you still have to do some lobbying to get health insurance at the forefront of what you're doing with the government. We also had to attach a face, a prominent face, which I must give a lot of credit to our First Lady, the wife of the governor, Dr. Folake Abdulrazak, who became an ambassador for implementation of health insurance in the state. So that gave us a leapfrogging for the commencement of the scheme. So even though we launched in 2018, we really didn't commence access to care until late 2020. But the lacuna we had between 2017 and 2020 allowed us actually to fine-tune our processes. Farm Access, supported heavily with consultants developing our benefit package and all of that. Now, we operate a totally digital platform for the administration of health insurance in the state. This gives us efficiencies, allows us to increase our reach, and makes it very transparent in the sense that all major critical stakeholders, on the platform have access to the platform, from our providers to enrollees and other third-party agents that support us in the implementation process. So the administration platform, the main frame of it is CarePay platform, into which other digital platforms flow. We have a registration platform, which is also digital, and we also have some other TPAs, platforms that interconnect with our mainframe, which is the main ICT frame. I must also say that we had to have sub-state structures, at the local government level and at the ward level that help us with advocacy, sensitization, so that that has greatly reduced our costs and improved efficiencies. We also have created feedback channels. We have a big call center that operates with toll-free lines, so that we can get response to questions or challenges or issues very quickly, and calls are routed from that call center to affected parties so that we can resolve issues in almost real time. We also considered our informal sector in the sense that they are not able to aggregate huge sums of money at a time. And we didn't want them to continue saving endlessly and not having access. So we have collaborations also with microfinance banks who provide very, very low interest loans and allows them to onboard health insurance immediately. And then they have a payback mechanism to service the loans. And that also has helped us with the informal sector to get them on board quickly without having to have a long waiting period to access health insurance. We also have, our own internal KPIs that we use to assess ourselves. Key performance indicators that we use internally to assess how well we're doing. And that has really helped us, to know where the issues are and, where we need to make some adjustments.
Okay.
Thank you.
Yeah, thanks a lot. Yeah, thanks a lot. You raised a couple of important points, and already, some questions are coming in for you, but we will get back to them after this round. Tees, you know that I have a soft spot for Philips, because as a kid we had this old Philips television, and that gave me access to watch football, and for that reason I supported PSV because they always had the Philips logo on their T-shirt. But having said that, Philips has also been doing very well on the UHC front, being an active member of the SDG Alliance, also at the United Nations level. Also the way that you look at your products and engagement of communities, I think particularly in Kenya, looking at sustainability of healthcare delivery. And certainly an important component of sustainability is financing. And I would like to have your take on what do you consider to be the key challenges there, and how Philips is contributing to address these challenges.
Sure, thank you, and welcome everyone, and thanks for this opportunity to speak. Yeah, maybe very briefly, as Kwasi already indicated, Philips has transformed from a very diverse technology company doing televisions and light bulbs and a little bit of healthcare equipment to nowadays a focused health technology company. So by now we have sold off all our non-healthcare businesses and we are purely focusing on health technology. And so we develop solutions along what we call the continuum of care for healthy living, prevention, through diagnosis, treatment, and home care. And we are in the middle of a second transformation because we are from a hardware medical equipment company, we are transforming into becoming a digital healthcare company. And all of this is driven by our mission. So our mission is to improve people's lives. And we set ourselves an ambitious goal that by the year 2030, we want to improve 2.5 billion lives globally. And part of that are lives in what we call access to care countries. Those are countries across the world where the population has a below average access to healthcare. And that is roughly half the world. So as part of our 2.5 billion lives to be improved, we also set ourselves the goal of improving 400 million lives in these access to care countries by 2030. And our auditors are measuring these numbers every year. So in our annual report, you can see how we are progressing against these ambitious goals. You may wonder, why is a company like Philips interested in insurance or in health insurance? Well, I think there's a couple of reasons for it. First of all, of course, we all see the benefits that health insurance can provide to patients in terms of financial protection and preventing catastrophic health expenses. But we also believe health insurance can be an important instrument for improving the quality of care and reducing the cost of care. And for instance, by moving from input-based financing models, as we see a lot in African public sector systems, to a more output or even outcome-based payment model. And of course, also value-based care. I think in a lot of countries, in Africa, the challenge is how to get people enrolled into a health insurance system. In some of the Western countries, people are enrolled, but the challenge is how to keep healthcare affordable. And that is where value-based care can play an important role. And that is where companies like Philips that bring technology solutions can work together with insurance companies to make sure that healthcare continues to be affordable. Coming to your question, Kwasi, access to financing. Indeed, we sell solutions for improving the quality of care. And I think one of the main barriers that we see in access to care countries is there is simply not enough money in the system to finance quality basic care. Of course, many governments have relied heavily on donor funding, but we increasingly see that countries, especially when they move into the middle income ranks, donors are slowly pulling out, and there is a gap. Governments are not able or not willing to invest enough in healthcare. We probably all know that very few countries in Africa met the commitments, the so-called Abuja Declaration, to spend 15% of their government budget on healthcare. Most countries are below or way below that commitment. And where donors are pulling out, there is a financing gap. And we think that, that insurance can play an important role in closing that gap. Why? Because if donors are pulling out, if government is not able to invest enough in healthcare, then many people are looking at commercial investors or impact investors to close that financing gap. But of course, such investors, they are businesses. They want to see a return on their investment, even if it may be a modest return for impact investors. So what is needed are business models that are bankable, that have an acceptable risk level for financiers. And insurance can play a critical role there, because insurance, if I look at the public sector, insurance can be an additional revenue flow next to investments by the government. And of course, also in the private sector, insurance can play a big role in making sure that there is efficiency and that there's quality of care. So what we do a lot as Philips, we develop and we test business models that make quality healthcare sustainable, operationally sustainable and financially sustainable. And in many cases, insurance is an important revenue flow to make such models possible and to make them bankable. And as a sign of our commitment, we are also even going to the step now of investing ourselves in some of these impact investment funds. So we have already signed an agreement with the Dutch Development Bank, FMO, to co-finance project development for large-scale primary care transformation projects. And we are at the verge of investing in 2 impact investment funds that focus on primary care in Africa. So we're also going to the extent of investing our own money into making sure that there is financing available for these sustainable primary care models. And let me stop there for now.
Yeah, thanks a lot, Tis. I'm sure there will be some responses in the Q&A, but also in the chat for some of the things that you raised. And making healthcare bankable certainly is a way towards sustainability. Kevin, I know FSD as the enterprise, the entity involved in financial inclusion, and financial inclusion, consists of a wide range of activities. But I would like to talk to you particularly about insurance. So what FSD is doing to promote health insurance, some of the key lessons that you've learned in doing that, and how those key lessons inform how you look at achieving development impact. Please.
Great, thanks, Kwasi, and greetings to everyone that's joining from around the world. Great to be with you. And so yeah, FSD Africa, we're a development agency, and so we're concerned about achieving market transformation in financial markets, and with the goal of economic development and reducing poverty. And so, as we think about the health space, I think the main lesson is we try and think about it as holistically as possible. So actually, because we're not really thinking primarily about insurance, we're thinking more broadly about health finance. By health finance, I mean sort of the mobilization of finance for health, the pooling, which is insurance, and then the allocation of that healthcare financing to infrastructure and healthcare providers and the like. And also holistically, we need to work across the public sector, the private sector, solutions like Tis was talking about, and also on the enabling environment. So I think that's the lesson from the work that we're doing, is that we take an holistic approach to health finance, and we're interested in achieving real and social sector outcomes for beneficiaries. So in the health space, that means 2 things. We want financial resilience to health shocks, and we also want health outcomes. And so that's really value to the patient. It's the same value-based care approach that Tis was talking about, where value is a function of both cost and quality. And so in the interventions that we're doing, we're not just looking, for example, for access to healthcare, but we're looking for health outcomes to actually be achieved, and for affordability. And so that's kind of our approach, and we're largely focused on solving the intractable challenges that exist in developing markets in terms of health finance. And I mean, a lot of those have already been mentioned. You have a fragmented health financing landscape, which means high out-of-pocket health expenditure. You've got money being spent, and Olamide spoke about increasing spend, but often that spend doesn't translate into better outcomes because the value is lost in the system. You often also have catastrophic expenditure on preventable health conditions. So Dr. Lydia was also talking about that. If you just focus on curative and not preventative, then you end up with large tertiary care expenditure where it could have been dealt with at the primary care level. And particularly in maternal health, that's an issue. And then you also have often a lack of data for decision-making and transparency, which kind of speaks to those other problems, but also leads to a lack of investment in the healthcare sector. And so this session is about technology and data, and I think technology and data can speak to a lot of those challenges. And so in terms of FSD Africa and our approach, we really big on trying to leverage both of those things to solve some of these challenges in a holistic way as possible. I'll stop there and maybe later can talk about some of the particular interventions that we're doing that speak to those things.
Yes, we will certainly talk about the role of technology. But could you share one or two lessons that you've learned from what you've done so far?
Okay, so I think the this is a complex problem, and there's no silver bullet, and so I think the main lesson is that you've got to take a holistic approach as possible. And so when it comes to health financing, where you've got fragmentation in the health financing landscape, it's not just a case of solving it through making the public scheme more efficient. You also need to work on deepening the private sector solutions and creating business models like Tess was saying that enable greater access. You also need to look to the long term to create enabling environment that facilitates both the private sector and the public sector to increase access. And so, yeah, I think that's the main lesson.
Yeah, thanks a lot. So we now move on to technology, and I would like to start with Lydia from NHIA Ghana. And if you could share with us how NHIA is leveraging technology to improve its operations, but also achieve more impact, basically.
Okay. Thank you very much. When we started, it was kind of just a random scheme giving people laminated cards and things. And as we all know, accountability becomes very key. So we developed a national biometric database. That was key for us. And it makes membership of the scheme very portable. Wherever you are, you can access care in the country. But then we added the ability to renew your annual membership on your mobile phone. And that has been a big game changer. We did that 2 years ago. And what we found was the informal sector, who cannot afford to take a day off to go to a district office and queue up to renew their membership, suddenly all came back on board as active members. And 80 to 90% of our renewals are done by members themselves on their mobile phones. That has happened within 2 years of the launch, without much money being spent on marketing and advertising. So it shows that technology was a needed intervention. I noticed the question in the Q&A. The informal sector has shot up from 29% of our membership to 36% of our membership. We've added almost 1.8 million active members back onto the scheme from the informal sector, just because of the ability to renew their membership themselves on their mobile phones. Big game changer for us. The next thing we then did was, fine, the providers must have the ability to authenticate each visit, again, using mobile technology. And it allows us to know ahead of time how many people have actually utilized the services and therefore what claims we can expect. And this is actually, we didn't actually see the import of it until the COVID pandemic hit us. We were getting 3 million utilizations a month. The first month of the pandemic, this dropped to 1.9 million visits. That was like a 30% plus drop. And NHIA was not dealing with the pandemic. The COVID was being paid for as a public health emergency. This meant that 30% plus of people who would normally go to the hospital or clinic stopped going. And it took us almost a year to get back to the 3 million visits a month. And, you know, one wonders, we're now doing the analysis of it. who were the people who lost out? I can bet you it's the diabetics, the hypertensives, etc. And that means we're storing up challenges for ourselves. The credentialing now is again online. You apply online. You don't have to go to any office. You load up your documents. If you have a good record, we can renew your application. If there have been some quality challenges through the year, we will do an inspection to make sure you are still providing quality care. We've done facility mapping. It's not fully done, but what it means is we are developing a mobile app that on your phone, when you need healthcare, it will tell you the nearest facilities in your locality and the staffing. So you know that if you're a pregnant woman, you don't need to go to a facility without a midwife or antenatal care services, etc. And the big one for us is electronic claims. We started off around 20%. We're now at 45%. But the issue is the data we're getting from these electronic claims fed back into the health sector has great implications for how the health sector is run. We recently decided to look at hypertension. NCDs are a big issue. What we realized that hypertension and diabetes, about 30% who are first diagnosed with hypertension and diabetes, the claim comes in, there is no follow-up visit anywhere within the NHIS for those people. Either they didn't accept the diagnosis. We all know that often you are well for a long time before you get real ill effects. So you go, they've seen you've got hypertension, they diagnose you, and you decide, well, you're well, you're never going to come back to the hospital. 3-4 years down the line, that person is going to come with a stroke, a heart attack, kidney failure, something. This information fed back to the health sector actually will change how we handle the early onset of these NCDs. So for us, technology is working out to be a game changer. And we are linking the membership of the NHIE card now to our national ID. It's only just being rolled out, but that gives immense potential around preventive care. When you know who your citizens are, their demographics, their social status, you can actually design good preventive care services and put that within the health insurance benefit package and pay for it in a financially sustainable way. And we think that is the next big game changer, but it really relies on us being able to roll out the appropriate technology.
Yeah,
thank you very much, Kwesi.
Yeah, thank you very much. Yeah. So let me go to Kevin and emphasize one point that Lydia raised, and that is basically, if you're dealing with informal sector, it's a group that can pay more, and they can pay more than they can earn. So basically, we got to use means that will help us extend coverage at minimum cost, and technology plays that role. And if you could share with us what FSD is doing in using technology to promote financial access.
Great, thanks, Kwesi. Yeah, I was nodding a lot there because I think all of that is really fantastic. And I think, technology, as you said, Kwesi, it enables lower cost operations, which is so critical in health insurance schemes where funding is limited and margins are low, and so that's key. But I think also technology enables distribution and digitization of other parts of the customer journey. And then, as Dr. Lydia was talking about, it enables data, which is so critical for the operation of health insurance schemes. And so we're supporting on all of those different things. Maybe just to start on the data side. So we're working with both private and public sector on utilizing data to introduce more value into the healthcare system, and particularly relevant, I guess, to this conversation is working together with Farm Access and NHIA in Ghana to leverage data to reduce costs, but also to ensure more quality. And on the cost side, it's exactly what Dr. Lydia was saying, to identify clinical pathways that they end up in tertiary care and in large amounts of expenditure that could be dealt with more effectively by preventative care, introducing those into the benefit package. So having the right data and analysis enables you to do that. But also importantly, there's the quality angle, and so if there's quality feedback loops between the payer and the provider and the patients, that enables you to then to start to create the right incentives in the structure to drive outcomes. And so because the National Health Insurance Scheme has a lot of leverage with the providers, they can, if they have this kind of data on outcomes, can design the way that they contract with the providers so that it incentivizes outcomes rather than just volume of care. And so you can then drive quality in the system, using the leverage that you have as the National Health Insurance Scheme. And so those are some of the things that we are working together with NHA and Farm Access on in Ghana, but also within the private sector. And then on the distribution side and customer journey side, I think digital platforms provide a great way to grow and create a sustainable pathway for health insurance, especially in the private sector side. And so, we're working with one of the large MNOs in Africa to develop new health solutions to distribute to their mobile money customers. And there we're talking not just about health insurance, but healthcare solutions that are more holistic. And next year we'll be publishing a paper that kind of highlights the principles that were used in developing those products and some of the lessons learned. But we're also looking at supporting remittance service providers who, there's a large amount of money that's sent from out of Africa to Africa in form of remittances, and we've done a lot of research, and the main thing that's for is actually health. And so it makes sense to segregate some of that money for pre-funded healthcare. And so we're working with RSPs to kind of develop products that enable that as well. So lots of use cases for technology and data, but I'll leave it there.
Yeah. Thanks, Kevin. So we have heard from NHIA, we've heard from FSD, working across various countries. And now let's zoom in to a state level. In Kenya, there was a county, and there Bumi is working with Kwara State. And Bumi, you explained part of it when you talked about the technology that you're using to ensure efficiency and facilitate enrollment and etc. Is there something else that you want to add based on what Lydia and Kevin have said about leveraging technology and data for?
So thank you very much. For Kwara, we knew at the onset that we wanted to operate a digital platform. Again, like I said, to gain efficiencies, to increase reach, but we knew we had limitations because the more you go into the grassroots, the less the literacy levels, and because of the rate of poverty, that also affects the ability of people to possess phones and all that. And so what we did was that we created substructures at the local government level and at the ward level, people who we are trained on how to use digital platforms. So registration, for example, can be done at a ward level because we have agents there who have the registration platform and the hardware, and they can register people, and we can receive the data from our office in the central zone. And so that has really helped us to gain traction. So if a community, for example, invites us to register their folks or they want to enroll, we don't really need to leave our office. We can, use our substructures, the agents where we have them there to go out and do that for us. Once you register, your policy number is transmitted to you via your phone. And from your phone, it also lets you know what next you need to do after you have registered. We also have POS agents distributed across the state to make payments convenient for those who can't use a USSD code. We have that as well as a payment mechanism. And for Kwara, as you leave the metropolises, you have less banking structures. So we heavily rely on point of service agents distributed in the state. For us, the digital platform does multiple things. One, it's the major admin platform. The data from the registration platform feeds into the mainframe, and so we can get data, in real time for those who register and those who enroll. Our providers also, of course, connect with us via the admin platform, which is ICT based. So all the utilizations, encounters, are fed into our mainframe, and we get the data. And of course, the data analysis helps us, to make better decisions, to know what is happening, especially post-pandemic era. We want to know what is happening with our beneficiaries across the state. I must also say that we actually provided access to care. I was listening to Lydia in the midst of the pandemic because the pandemic hit and there was so much scare, and suddenly all our chronic care patients disappeared. And all our channeling was towards fighting the pandemic, and we were sort of wondering how they were being taken care of. And we had to make a case to the government that this would have been the best time for us to launch the scheme, because everybody suddenly disappeared, and we knew that the chronic illnesses didn't disappear with them. And like Lydia said, we were in for trouble later because of complications from those NCDs. And so, and also communication largely is done via digital platforms. We have all kinds of social media platforms that we use to engage people at the sub-state levels. We use social media, Twitter, WhatsApp, to get across to our beneficiaries, whether we're sensitizing, whether we're disseminating information. So we largely depend really on these digital platforms for us to be able to implement the scheme.
Yeah, thanks a lot. So Tis, you've heard from the health insurance agencies in this webinar, also from FSD, a development agency. As a multinational, Philips, could you also share your experiences, some results that you have achieved, how you using technology to deliver care? I know that you have the community life centers, which you could perhaps explain that a bit. That digitalization, in the broader sense, how is Philips using that to ensure that millions of people who do not have care will have access to care?
Sure. Yes, so a number of years ago, Philips decided to start focusing on community and primary care, which has never been a focus of large health tech companies like Philips. Because we believe that that is the best place to invest in improving health outcomes. And of course, we're not alone. I think the World Bank and WHO and others would confirm. And when we analyzed the challenges at that first level of healthcare systems, we found there were many. Lack of infrastructure like electricity or water, lack of technology, lack of staff. So what we decided to do was to develop a comprehensive package that could help in improving that first layer of healthcare. And the name we came up with for that package is Community Life Center, or CLC, because our vision is that those primary care facilities can be the center of community life, not only for healthcare, but also for prevention, clean water, and other things. So that's where we started a number of years ago. And then over time, we realized the potential of digital solutions in improving that first layer of healthcare. I think for a number of reasons. One is task shifting. Typically, at that first layer of healthcare systems, you don't find doctors. You find nurses or clinical officers or midwives, but you don't find doctors, and doctors are scarce. So through technology, you can support those lower level healthcare workers at the primary care level to still make a diagnosis and do a proper treatment. So that is why we started developing digital solutions that have a built-in clinical decision support functionality to help those health workers on properly treating patients. Secondly, adherence to protocols. I think one of the big challenges is that many health workers do not follow the proper protocols in terms of how to diagnose and treat patients. So through some of our digital solutions, we can support these health workers in making sure that they follow the right steps in the process, that they refer at the right point in the care path, etc. But also, of course, digital solutions can connect different layers of the healthcare system together. So for instance, we developed a solution for mother and child care. It's called MOM, which stands for Mobile Obstetric Monitoring. It's a cloud-based digital solution that connects the patient to the primary care facility, to the hospital, all in one system. So the patient, through an app on her phone, gets access to educational information about her pregnancy. But also after delivery, she can, for instance, screen herself for postnatal depression. She can monitor the development of her child, etc. Then at the primary care level, there is a community health worker app that can be used by midwives or other staff at the primary care level that helps them to register patients, to access patient data, but also to enter data. Let's say they screen the patient or they take their temperature or blood pressure or other vital signs. All of that information can be stored in the system. And then finally, the doctor sitting in the hospital can oversee the patient population through that same system. Patients are automatically organized into risk categories, low risk, medium risk, high risk, where the high risk patients, the recommendation is that they deliver in the hospital because there may be a need for C-sections. So I think that's an example of how digital solutions can make the whole health system work better. And the next step, which we are now exploring, is linking these clinical applications to payment applications. So together with PharmAccess and CarePay in Kenya, we are doing a pilot where some of the clinical information that comes from that Philips MOM system is linked to the MTIBA payment platform. And that opens up a whole new world of opportunities, because instead of an insurance company reimbursing for, let's say, an antenatal care visit, the insurance companies can now start reimbursing certain clinical outcomes. They can, for instance, say, if a woman completes her 4 antenatal visits, that will trigger an extra payment. So I believe we're only at the verge of starting to explore that potential. And it's something that we are really excited about, and that we are very open to working with others in that field on looking at how can we use clinical data to link to payment data in order to improve the whole system. Thank you.
Yeah, thanks a lot, Tis, and certainly we are enthusiastic about the collaboration and that we have with Philips, with NHIA, with Kwara State, with FSD, and certainly with the World Bank in Nigeria. And Olumide, to get back to you, you've heard about the specific actions taken by these organizations to improve financing and delivery of care when it comes to technology. From the World Bank's perspective, and as senior health specialist, what's your take? What have been the efforts of the World Bank in supporting entities, states, countries to leverage technology and data?
Thank you very much. And there's been a whole lot of interesting learnings, innovations already discussed by our distinguished panelists, especially from the field. But perhaps it might be important to take a step back. One of the things I mentioned at the start of the panel is the cardinal role of public financing and general revenues, and also saying that indeed without that, the hopes of attaining universality will be a mirage indeed. And we also know that this is a pulse that is shrinking, especially with what has happened most recently. It then means that there will be a need to prioritize the little we have. And in prioritizing access that way, it means that we probably want to take care of those who require some form of support. That is the poorest and the most vulnerable in our societies. So in economies that are constrained with their public financing, perhaps one way to be able to allocate resources will be to better identify who these beneficiaries are, and that certainly, I think, is almost a sine qua non for several of our countries in which we work in. You would then expect that there will be the availability of things like a single registry or a national social register for the poor. I know that Ghana has made some progress in this, and I think Dr. Lydia was saying, now this is somewhat being merged. That certainly will be a very strong role for the use of technology, where you have all of these digital registries that allows social services to be delivered to the poor and vulnerable. The kind of efficiencies that can be obtained there, I think, is something that needs to be emphasized. The several things that have been said on the supply side, I really, cannot, I can only just marvel at the level of innovation that's happening on the field. But without this kind of innovations, again, we will not be able to we will not be able to extract maximum value for the amount of money is being spent. The big question then is, how do we take these things that's been described to scale? And one area where we do not even have a choice is now a lot of data is coming in through provider payments, and the fact that technology mediates all of those provider payments. There certainly will be a need to use things like artificial intelligence to be able to make sense of this big data that is emerging, especially in several of our countries. It can only get efficient going forward. So indeed, the bank works with several entities to pilot, to test some of these innovations. But I think the game-changing effort will be when we begin to take several of these things to scale. Thank you.
Yeah, thank you very much. Thank you very much, Olumide, on this, and we do really appreciate the support and that the bank has given to the promotion of state health insurance in Nigeria. If you just joined us, we are in a session on leveraging technology, mobile technology, to enhance financing of health. And we've been listening to Dr. Lydia Selvi, CEO, National Health Insurance Authority, Ghana, Dr. Olumide Okunola, Senior Health Specialist of the World Bank based in Nigeria, Tis Cruising, Venture Leader, Connected Primary Care Solutions, Philips, Dr. Bumi Jetta-Winter, Executive Secretary, Kwara State Health Insurance Agency, and Kevin Massingham, Director, Risk and Resilience, FSD Africa. Some questions are coming. So I would like us to have interactions with the audience on these questions. And I think the first one I have here is on gender split within your schemes. Briefly, Bumi, what is how are you encouraging the participation of women, adolescent girls, etc. in the scheme? And the same will go to Lydia, of course.
Thank you, Kwasi. In the implementation of our scheme, a lot of emphasis is made, especially within the indigent population, to onboard children under 5 and women of adolescent age. So we specifically look out for those in our indigent population, and we try to mop them up quickly. We also have social programs that target women as a platform for us to advocate to them and to get them on board. A lot of my advocacies, I try to identify women who have some understanding of what health insurance, the value in having health insurance at the local level, and they become ambassadors in propagating health insurance administration to others. So we normally would have women groups who we advocate to, and the governor, part of his policy thrust is that he wants to improve the health indices for children under 5 and adolescents. So a lot of emphasis is placed on them.
Yeah, thank you. We get into conclusion, so I appreciate the responses.
If I could just say,
brief.
Sorry, if I could just say something to further buttress what Tees was discussing about. If you look at the impact of technology driven schemes, I know that in the health system, every card that we issue out to a beneficiary has their biodata, has their next of kin, and you'd be amazed about how that improves services, even at provider level. We were in a system where if somebody was brought unconscious, for example, to the hospital, it would take weeks for us to be able to trace their wards, their families, and they would be there and nobody would care for them. But with the advent of health insurance schemes and the availability of a health insurance card, just simply, identifying the person through their policy numbers opens up a lot of data on them, their blood groups, so that care can commence immediately in emergent situations, and also to be able to even contact their next of kin who would be worrying. So I just wanted to buttress, what T said about data gathering and how technology improves efficiencies.
Yeah, thank you. Lydia, please.
Thank you very much. Our gender split of active memberships is 60% female to 40% male. And I would, no research has been done specifically, but I would like to think our males tend to be a little macho and feel they don't necessarily need constant health care. What we have found, though, on the research we have done is that for a household to have NHIS membership and stay active, it depends mainly on the woman of the household and her educational level. It's the females who are driving NHIS membership. And if you have an educated woman heading a household, the chances of the whole household being on health insurance and staying active is high. With regards to different categories, the under 18s pay no premium. They're part of the exempt group. So they form about 42% of our membership at any time. Under 5s do not serve a waiting period. As soon as you want a card, you get it, you can go to the hospital straight away to help with the under 5 mortality. So I think these are some of the things we do to try to balance out gender and the vulnerable. Thank you.
Yeah, thanks a lot. There's a question about how do you ensure private sector participation? But I think you address it, right? In your
Yes. I saw the question. It's more about private health insurance, and this is the national scheme. The private health insurance is separate, although we do regulate them and we help them set up more resilient systems to try to grow the sector.
Yeah, thank you. Tis, there's a question about, you mentioned the collaboration with FMO, and there's a question about how is the capital structured, and is it a loan or equity? How do they get access to this facility?
Sure, yes. And I should say this collaboration that I refer to is with FMO. However, that specific department of FMO recently moved into a new organization called Invest International in the Netherlands. But apart from that, so that collaboration is for project development funding. Because what people sometimes forget is to develop a project to the point where it is bankable is a lot of work and is a process that can easily take a number of years. For instance, we are developing a public-private partnership with a decentral government in Kenya, and we've been working on that for over 3 years now. So one of the challenges is who is paying for all that project development work? That may be consultancy, that may be pilot testing of new solutions or new business models, etc. And that is the area where we partner with FMO. So FMO has a scheme where they provide, as they call it, conditional grants. So that is money that is being invested in project development for projects that have the potential to go to scale and to become sustainable. And then the way it works, if the project does indeed successfully go to scale, then the money has to be paid back with a success fee on top. But if the project development is not successful and does not lead to a scalable project, then the money is, let's say, written off and it's granted. So that is the structure of the funding that FMO provides in that collaboration with Philips. Our part of that project development arrangement can be in different forms. So in some cases, we can, for instance, provide our technology at reduced prices where the rest of the payment will happen if an initiative successfully goes to scale, or we can extend payment terms, etc. So we have certain flexibility on how we structure our part of the funding. On the FMO side, it's through this so-called conditional or repayable grant.
Yeah, thanks. Thanks, Tis. Olumide, there's another elephant in this room, and that is, if you look at Ghana, the government pays like 70% of the cost of insurance, and Nigeria is trailing on that. And the question is, what are the challenges that the state and federal government face in enhancing the financing of care, and how can they overcome these challenges?
Thank you, Kwasi. I think I already made a point on the fact that our governments at both the national and state level are unable to raise the quantum of revenues that is required to support the population in their human capital development aspirations. And without it, every other thing is academic. And that's why everyone on this call, we need to support governments to say, well, even within the very little that's available, how do we prioritize? Because the future of economic growth for any country is dependent upon its people. So yes, it's a tough one for any minister of finance to say, well, how do I give to health and education when I don't even have enough in the purse? And I also emphasize that, in fact, health stakeholders, this is the time to be in that kitchen where the cake is being baked, because we can now push for increased taxes in alcohol, tobacco, sugar sweetened beverages, things that we have not necessarily looked at before. Several African countries, for instance, are not doing or raising enough revenues from those health bags, and we can ask for it to be earmarked. And again, at the state level in particular, there's a big elephant in the room, as you mentioned. You have several states that are still using the principles of passive purchasing, if I put it that way, still allocating monies to providers through ministries of health. And at the same time, still trying to use the likes of Dr. Jetawo Winters to purchase care through these quasi-autonomous organizations like the state health insurance agencies. It might perhaps be best that governments in our part of the world begin to consolidate and take a decision to say, well, which of this arrangement will buy the best care for me? You know, where would I get the best efficiencies out from? You know, so that really, I think, is one big question that we will need to tackle. We can't do both at the same time, you know, and I believe that with the current crisis, this is probably the time that we can make some tough and bold decisions to most principally expand the principles of strategic purchasing with a defined package, contracting providers, both public and private, you know, and deploying the most suitable provider payment method that works. And of course, having an ICT platform that helps mediate all of this. Thanks.
Yeah. No, thanks a lot. Thanks a lot. And I know, you know, you've been working on this for some time and have made some progress. In my view, the question is, how do you build on this progress? I think an important progress is the basic healthcare provision fund. And it's more about how do you expand it to ensure that more people are covered. So thanks a lot for that. Kevin, we've been discussing technology, data, and so far we've looked only at the potential, the possibilities, but certainly there must be also limitations and risks associated with data and technology. Could you share your thoughts with us on this?
Sure, thanks, Kwasi. Yes, obviously, health insurance is a complex problem, and it's something that this community and the insurance industry, we've been trying to crack for a long time. And so there's no silver bullets, and technology and data, you know, obviously are very key in solving the problem, but there are limitations. I mean, if you talk just about data, I mean, data is obviously key for pricing of risk in a health insurance scheme, but data by itself is not that useful. You need a kind of ecosystem around it. The data needs to be accessible, you know, so you need like health information systems where it's not siloed. Data must be standardized and credible. So you need data standards and guidelines so that you're not using different definitions and the data is not syncable. You need obviously health data is sensitive, so you need data privacy and security rules and regulations and those to be applied. And then very importantly, you know, raw data by itself is not useful unless it's analyzed. And so you need like the resources with the technical skills to actually be able to analyze it and then make decisions. So you need a kind of ecosystem around data. But if you talk broadly about technology and especially in digitizing kind of distribution and the customer journey, you know, that does have many advantages, but there's also limitations, you know, so customer education and trust needs to be overcome, and there's behavior change that's required in order to move from doing something that you did physically before to doing it virtually. And so, you know, I started 2 telemedicine companies, and so very much aware that that's a challenge in the telemedicine space, and that, you know, also health is an emotional issue, and so people want a human touch, and so there's a need to kind of build in that hybrid model. Technology, you know, and a completely digital customer journey, you know, can't solve all the problems, and obviously clinically as well. not all conditions can be done virtually. I mean, maybe just, I mean, like a follow on this challenge to TIS is, you know, with your community-based systems where you see like a nurse or a community health worker. I mean, I know that, you know, as with telemedicine, a lot of the challenges that people expect to be able to see a doctor, and so there's a sort of a trust barrier that needs to be broken. They're not willing to just speak to a nurse or speak to someone remotely if it's not, you know, they want to see a doctor and they want to. So how have you overcome that challenge with these community health? And interesting to know.
Yeah, thanks. And that's a very interesting challenge that you're raising. A couple of observations from our experience. First of all, what we have seen is that if a primary care facility is well equipped, that will increase the trust of patients in the facility. We have seen that in a number of cases. So for instance, if a primary care facility has an ultrasound, we see a lot more women coming to that facility for their antenatal checkups. So I think technology can help in building that trust. Secondly, technology also opens up the opportunity of doing telehealth. So some of our digital solutions have the ability to consult a doctor in a hospital in real time, in case, let's say, the nurse in a primary care facility may not be able to properly handle the issue of the patient. And thirdly, I would also say, because what we see in a lot of countries is that patients are used to going to a hospital for minor issues because that's what they're used to and that's where they have the trust. So what I always say to governments is, once your primary care system is working properly, you should no longer allow patients to just walk into a hospital and seek care. You should organize your system in such a way that patients must first go to a primary care facility, and only with the referral they can go to a hospital unless their condition is critical. So I think there's also a policy element here, but of course you can only implement that policy if you have a properly working primary care system.
Yeah. Thanks, Tis and Kevin. I think time is up. Within 2 minutes, we will close this session. So I would like to thank you all. I think the point on limitations and risk, Bumi, you mentioned already the low level of literacy at the community level and how that impedes the use of technology. And certainly there's also a gender gap, which others are addressing. But I would like to thank you all for exciting conversation, and hand it over now to Derek, who will give a closing remarks.
Thank you so much. I can only repeat what Lisa Morgan wrote in the chat. Big thank you for organizing such a fantastic panel of speakers. I'm not a health expert at all, but what I really like is this diversity in the sense of different stakeholders. We have worked with Farm Access over some years. We have been in Ghana, so some of the faces were familiar. To me, for example, seeing Philips coming to the discussions was new to me, and it's crystal clear that this is needed. So thank you very much. And now I'm really sad that we can't really continue that conversation over a coffee. Well, we can. There's a virtual coffee break, but we should certainly continue that conversation more frequently. So I'm really thrilled by that panel. Thank you so much. And I have so many open questions that are still remaining, new questions, new things that need to be addressed. And Olumide said two things that I noted down. Now, we need to think about what arrangement is the best, and this is about who's involved and who's part of a project, where can we fill gaps. I think that is important. And one thing, more general, the future of economic growth in any country depends on its people, and sick people are not good for economic growth. Sick people, unhealthy people are not good for any society. We need to increase resilience. And yesterday in one of the sessions, someone was saying, yeah, we were selling insurance to farmers and what they bought was health insurance. So maybe sometimes we think that a certain group needs a certain product, but we might be wrong and we have to think differently. Thank you very much. Now it's coffee break. You can join the virtual coffee break, and then I see you back in about 30 minutes.
Yeah, thanks a lot for your contributions.
Thank you.
Thank you.